topic on antibiotic overuse. It's a very, nowadays we come across antibiotic resistance very commonly. It's a much needed topic. Over to you, sir.
Nandal. At the outset, I would like to thank the organizing secretary, Dr. Ravichandran sir, and his team for giving me this opportunity. So this is a very meticulously organized conference. So it looks like a national conference. So all the communications, all the things they have did. So Dr. Ravi sir has put Kallakurichi a special place in the Indian map. Debut match century he has done a very huge thing. So my congratulations to the entire team. So the topic what I am going to talk for the few minutes is not a new one. So recently there is a roaring problem of antibiotic resistance. So the antibiotic pipeline is empty. So the past 10 years we don't have any new antibiotic molecule, and the mortality due to infectious disease is very high, and there are a lot of pan resistance microbes recently. So just I'll take you through small guidelines how to overcome this. And greetings from the ECG and Echo Club of Trichy, and salutes to my master and professor, Professor Chenniyappan sir. Without him I will not be standing here. So I'll start with this small thing. So when in 1950, when the various antibiotics were discovered, so the William Stewart, the Surgeon General of United States, has said this statement: the time has come to close the book on infectious disease, and we have wiped out infections from United States. So this is a thing that was thought at the time. But all the organisms has developed resistance, and we lost the miracle. So this is the state what we are now. So the antibiotics, most of the antibiotics, what we thought very gold standard and good antibiotics have, not at all working against the microbes. So I'll take you to a few case scenarios. So these are routine case scenarios where we see in our day-to-day practice. So 35-year-old non-diabetic comes with sore throat, dry cough, no fever, clear lungs for 3 days. So what is the prescription we can do? So all the 4 was given by 4 different practitioners. So this is routinely seen in day-to-day thing. So what can be given for this patient? Which option can be given? Okay, so this patient doesn't need any antibiotic, just some symptomatic treatment. So this is another case, 45-year-old male, diabetic, under control, fever with chills, dysuria, no loin pain or tenderness, no hypotension, total count 15,600, urine plenty of blood cells, no cast. So these are the 4 options here. Which option can be the best option here? So most often the option chosen was the IV antibiotics. But here the necessity for IV antibiotics is not there, because no shock, no pyelonephritis, all those things. It's a simple case of cystitis with urinary tract infection. So we can take a culture and we can start some small or low narrowest spectrum empirical antibiotic. So this is the third case, 32-year-old male, non-diabetic, high-grade fever, no chills, retroorbital pain, myalgia for 3 days, no localizable signs, no hypotension, takes orally, no rash. So what option can be the best option here? So here also it is only asymptomatic, because it is a viral illness. So what happens most of the time, few practitioners give ceftriaxone, some of them give doxycycline, and some of them give azithromycin. So the thing is, the practice of antibiotic prescription has become a mandatory thing. Like if you don't know what is the diagnosis, if you don't know what to put in the prescription, you start with some antibiotic, telling that because the patient has got admitted, so we can give antibiotic. And even if it is viral illness, we can give antibiotic for a superadded infection. So if there is no superadded infection, there is no need for antibiotic. So the problem is the unnecessary prescription of antibiotics. So this is the thing that we have to tell the youngsters, that fever is not a state of ceftriaxone deficiency. So whenever there is a fever in the complaints, the treatment will be ceftriaxone always. So this is the basic thing which we should change. So this is the current scenario. So India is the capital of gram-negative resistance very poor infection control practices, newer drugs are not available, even the available drugs are not affordable, and we have got lot of irrational combinations. So before the textbook brings that combination, the combination will be brought up by the pharma companies, and they don't have any regulatory control, and the antibiotic pipeline is empty. So this is what I said, the magnitude of the AMR, so antimicrobial resistance. These are the mortality due to the antimicrobial resistance. By 2050, it will be 10 million per year. So what are the causes for antibiotic resistance? These are the 6 important causes for antibiotic resistance. First one is the overprescribing of antibiotics, patient not finishing their treatment, overuse of antibiotics in livestock and fish farming. So this is a gray area where lot of antibiotic has been abused in the livestock and fish farming. Poor infection control practices, lack of hygiene and poor sanitation, and lack of new antibiotics being developed. So these are the factors which contribute to the development of antibiotic resistance. So what exactly the bacteria that gets resistant means? Whenever there is a resistant bacteria, this resistant bacteria can transfer the resistant gene to the susceptible bacteria. So the susceptible bacteria becomes a resistant bacteria. This is one more thing. This is the area where we play a major role by prescribing unnecessary antibiotics. Say for example, if there is 100 bacteria, the 80 bacteria will be susceptible and only the 20 bacterium will be the resistant strains. What we do, if you give unwanted antibiotic, you kill all the 80 susceptible bacteria and the 20 resistant bacteria will proliferate. So that is the thing. We are the only person responsible to trigger the proliferation of the resistant bacteria by killing the susceptible bacteria unnecessarily. So previously Sir has talked about the microbiome. So that is where if you take some antibiotic, they will destroy the entire microbiota. So this is the factors which these are called the drivers of antimicrobial resistance. So clinical, biological, social, political, environmental, and economic. So all are the drivers of antimicrobial resistance. So this is what I told. So a course of ciprofloxacin or clindamycin produces a change in the gut microbiome lasting up to 1 year with a maximum effect for 10 days. So if you take a single course of ciprofloxacin for a period of 3 to 5 days, your gut microbiota will be destroyed for a period of 1 year. So the effect can last for 1 year. So this is where we should know the magnitude of the problem. So the simple practice is just when you have a sore throat, if the sore throat you are not getting relieved in 1 or 2 days, the practice is taking azithromycin for 5 days. So even we people also doing the same thing. So this single course of antibiotic can do a lot of problem like this. And they can change the oral, GI, respiratory as well as the vaginal flora. So once the microbiota is altered, as Sir told, we have lot of all pathological mechanisms come into play, like we get diabetes, we get ischemic heart disease, obesity, all those things will be a sequence of this altered microbiota. So why we use antibiotic unnecessarily? Because there is a lot of peer pressure while practicing. So if the patient comes to you with upper respiratory tract infection, if you don't put antibiotic, and after 3 days if he goes to some other practitioner and he prescribes an antibiotic, and the patient will become better. But the basic fact is, even if you don't prescribe antibiotic also, he will become better. So what we understand and the patient understands, so only if you put antibiotic, we will get cured. So that fear of having that peer pressure will start antibiotic. So what we think is, broader is better. Sickness requires immediate treatment. Failure to respond is failure to cover. So response implies diagnosis. Just if you put an antibiotic and the patient responds, we think that diagnosis is infection. So that should not be like that. So when in doubt, change drugs. More disease, more drugs. Bigger disease, bigger drugs. Bigger disease, newer drugs. And antibiotics are harmless. So these are the fallacies what we think in our mind, and we start antibiotics unnecessarily. So this is called the 30% rule. So over 30% of antibiotics are prescribed inappropriately in the community. 30% of hospitalized inpatients at any given time receive antibiotics. Up to 30% of the surgical prophylaxis is inappropriate. 30% hospital pharmacy cost due to antibiotics, and 10 to 30% of the antimicrobial cost can be saved by antimicrobial stewardship program. So while implementing this antibiotic policy, we get all these benefits, including the economic benefits also. So unnecessary prescribing antibiotic cost. So what will happen if we do not address this issue now? So the post-antibiotic world will have a lot of consequences. So minor injuries could be deadly. A return to obsolete treatment such as amputations, because previously what happened for tuberculosis, they have done lobectomy, pneumonectomy, all those things were previously practiced. So we'll be going to the same era if you don't address this antibiotic abuse. Longer duration of illness and hospitalization will be there, and poor clinical outcomes. increased cost of therapy, and drug adverse effects like antibiotic-induced infections like the Clostridium difficile. So these are the consequences we are going to face if you don't cut down our unnecessary antibiotics and prevent antimicrobial resistance. So these are the strategies and antimicrobial for combating the antimicrobial resistance. So the first and foremost thing is immunization, sanitization, and infection control. So these are the basic things which can cut down the necessary for antibiotics. Next is encourage the discourage the antibiotic overuse and encourage the antibiotic stewardship. Reduce the use in the agriculture, farming, and the fish farming, all those things. Educate the healthcare professionals, and we have to make sure that the administration is also involved in the AMR practices. So it should be an integrated approach. So you should have a diagnostic stewardship. So very good diagnosis can also minimize the antibiotic use. Infection prevention can also minimize the antibiotic use, and the antimicrobial stewardship. So it should be a combined effort. It should be an integrated approach to implement the antimicrobial stewardship. So the CDC has defined the antimicrobial stewardship as the right antibiotic for the right patient at the right time, the right dose, right route, and causing least harm to the patient and the future patients. So this is the the thing which CDC has defined what we have to follow when you think of prescribing an antibiotic. These are the factors we have to keep in mind before choosing an antibiotic. So what we have to change? So what are the steps we can take to address this antimicrobial overuse and the emergence of antimicrobial resistance? The first thing is the approach to treatment should be changed. So diagnosis is not everything, it is the only thing. First you should focus more on the diagnosis rather than initiating the treatment. So first you have to focus on the diagnosis. First you should have the problem list, and you should have the probable diagnosis. Number 1, number 2, number 3, number 4, like that. So this is the first step in addressing this issue. So choosing the diagnostic test wisely. So just because we cannot order a blanket type of test, there is called a fever panel. So if a patient comes for a fever, we'll do all the fever investigation, both bacterial and viral. So all those things should not be done. So your investigation should be a focused one, because unnecessary investigations will lead to unnecessary prescription of antibiotics. So this is one case where a 32-year-old male, non-diabetic, high-grade fever, no chills, retroorbital pain, this case previously discussed. Which investigation is not appropriate here? So here the blood Vidal is not appropriate here, because it has become an absolute test for the past 5 to 10 years. So nobody using Vidal test. And another thing is, whenever the patient goes to a lab, that person will do all the CBC, MP, MF, and Vidal. So even if you do Vidal, you cannot do it in the first week, because only in the second week the antibiotic will come. So you cannot do Vidal in the first week, and the patient will carry that Vidal report 1:80 dilution for years together, and they will be getting ceftriaxone every year. And the patient will come and say that every year I used to have typhoid in the December month, and used to get 5 days antibiotic. So this is the basic thing we have to educate the people. So appropriate empiric therapy should be done. So empiric therapy should be based on the guidelines, and start antibiotics early in critically ill patients. So just don't think that you should not use antibiotics, because the patient comes with severe pyelonephritis, shock, and organ damage. You have to start higher antibiotics. But the thing is, you have to justify the antibiotics and de-escalate after 3 days with the appropriate culture reports. So de-escalation is very important thing. So what will happen whenever you put a patient on piperacillin tazobactam? After 3 days, the urine culture comes and sensitive to gentamicin. We never de-escalate, we never change the piptas to gentamicin. Just you continue piptas for 7 days. So that should not be there. You should immediately de-escalate with the narrowest spectrum of antibiotic for a shorter duration of time. So follow the guidelines and reducing the duration, and switch to oral therapy as early as possible. So it is doesn't mean that whenever the patient is inside the hospital, you should always receive an IV antibiotics. So even oral antibiotics are better and equal to IV antibiotics in most of the situations. So how long to treat? This is one important scenario. So you have to shorter the better. So no guideline says antibiotic for more than 7 days, except in few scenarios like renal abscesses, meningitis, and other things. The duration is for 2 weeks or 3 weeks. All other things, all the guidelines says less than 7 days. So you can go and search the up to date. So everything, the guidelines is there for only less than 7 days. So you have to use procalcitonin. The use is better in pneumonia. So I'll go to the takeaways. So delay prescribing antimicrobials whenever possible. Choose empirical antibiotic based on the principles and guidelines. Order culture and susceptibility testing whenever possible before prescribing antibiotics. So we should have a culture of sending cultures. Avoid prescribing antibiotics when viral infections is the likely cause. Avoid broad spectrum antibiotics for less severe illness. Do not give antibiotics if there is a colonizer or contaminant. Like if you see a candida in the culture, don't go and try to treat the candida. Choose the right antibiotic and dose. Treat for the shortest duration. Re-evaluate your patient needs for antibiotics frequently. Discontinue antibiotics if a non-infectious mimic of a clinical syndrome. If you diagnose a SLE after 5 days, stop the antibiotics. De-escalate, switch from IV to oral antibiotic. Escalating antibiotic is not the solution for clinical deterioration or poor clinical response. This is one thing what we do in the ICU. If the patient's fever is not settling for 3 to 4 days, just you go and increase the antibiotic. So that should not be there. And the infection control practices are the cornerstone. So thank you for the patient listening.
Thank you, sir, for being here and enriching this event with your expertise.